I'm going to turn it over to Nancy Whitt, who's a director with our team on Health IT Solutions, and she is going to lead us through this next panel on the Crisis Bed Registry. So Nancy, take it away.
Good afternoon. Thanks for sticking with us. It's been a great conference for me. I hope it has for all of you. We are officially in the home stretch. As Melissa said, I'm Nancy Whitt. I'm on the Contexture team, and I have the privilege of working on the team that is standing up the Crisis Bed Registry. I work, more importantly, alongside really smart engineers such as Lori Klipfel, who is right here at the front. We have integration folks, project managers, designers, and we work alongside our partners and stakeholders, most importantly, to get this very important project going. So I do want to first introduce our panelists. We have an hour. For the first 10-15 minutes, I'm just going to talk about the bed registry. What's the history? What's the need? What are we doing now? What are we going to be doing? What's it going to look like? And then more importantly, I'm going to sit down with these folks because they can really tell you the important aspects of what this is going to do for facilities, but more importantly, for those that we serve. So on your left is CJ Loiselle. She is the crisis administrator at Access. And then next is Andrew Erwin. He is the COO at Solari. And next is Dana Neves, and she is the Business Systems Development Director at Community Bridges. So what is the need for a crisis bed registry? Well, I reached out to who turns out to be our gold sponsor, Mercy Care. Tanisha is their crisis and veterans administrator there. And I said, can you give me an indication of the numbers? What really is the need? Why do we need this? And she, you can see there the data. Over July 21 to July 22, for the Central GSA, which is what Mercy Care is over, which is Maricopa County and parts of Pinal, they had 241,000 crisis calls. And then about 11 of those resulted in a mobile team being dispatched. And the good news is 73% of those was resolved just as those mobile teams were intended to do, resolved right there where the crisis happened. And the folks got to go home. But there's always about 20% who need a higher level of care, perhaps an observation chair, perhaps an inpatient bed, and that's what the crisis registry tracks. So how do you go about building something like this? Well, first you look for the best practice. As you can imagine, this is data across the country that's very similar. There's a high need. And so SAMHSA, which is the Substance Abuse and Mental Health Administration for the federal government, started looking at this some time ago. They designed a big best practice guide that's very long, and I did read it. They call it their air traffic control model. And instead of me summing up my reading, I really loved what Paloma, who is the crisis coordinator at Access under CJ, said, and I want to read it to you. The air traffic control model is used as a metaphor for an effective crisis continuum nationwide and is referenced to draw a parallel to how the gold standard of crisis services should operate using closed-loop communication, similar to the way air traffic controllers manage the high pressures of air safety. The basic idea is that a person in crisis can be thought of similar to an airplane where the pilot is in constant communication with air traffic control, who has eyes on the plane at all times using GPS technology, ensures a warm handoff, and is completed at every stage in the flight and is able to see the information in real time to ensure the plane makes it to its destination safely. So I love the way she summed it up, and so that's why I wanted to read Paloma's words. So of course the response was use best practice. So I took this from a slide that CJ presented in the spring. And she said for Arizona to have a true crisis air traffic control model in line with best practice, a statewide crisis line provider, crisis mobile teams and REBAs must have access to real-time crisis observation and stabilization capacity data. So I'm pleased to say we have 3 partners in this project. Of course, Access is our funder, and we're working closely with Solari. So work began between Health Current. I say Health Current because this is an Arizona program, and Solari last year for a solution for Maricopa County. But then in 2022, Access received additional funding from the American Rescue Plan Act of 2021. It was a mental health block grant to support the remaining statewide implementation activities. And so we worked together over a couple months, and the task order was finalized in May, and we had a kickoff. So we did begin that work in 2021. So pilot providers were already chosen. They are Community Bridges, Connections, and RI International. They were initially going to be, it was going to be a Maricopa County pilot, but they have facilities all over the state. So we will start with a statewide pilot with these 3. And because we had already started working with them, it was pretty easy to get their scopes of work executed quickly and really start working on this new project. You know, the design work began in May. It was approved by Access. We had input from Solari. And then the scopes of work for the balance of the crisis registry bed providers will be executed by the end of this month. And of course, we work closely with Access and meet with them at minimum at once a month. So here you see our participants. They are separated into pilot providers, first round and second round. The pilots will go first, obviously. I'll give you the timeline in a minute. And then first round just means we're going to engage that list first. And then the second round is we're going to engage that list after that. This is not an inclusive list. We have others that are going to be joining. So again, work continues now with the pilot providers, and the pilot will go live on January 6th. The work that has to be done on the provider level is for that HL7 data to be able to come over to us through their vendor, and I'll explain that in a moment. The pilot will be live through March of 2023. The first line providers will start migrating over, doing their work after that, and then the second. And the plan is to have everyone go live by March of 2024. So the crisis bed registry is basically an enterprise database. It can receive information from the crisis providers, hopefully automatically. HL7, as you know, is that admit, discharge, transfer language. And in a hospital, that's pretty automatic. But for crisis providers, you know, they have to work with their vendors to be able to send those HL7 messages automatically. That way it'll be seamless. You know, somebody in crisis comes in, they're admitted to an observation chair, they document the admit, and it goes right to the registry. Some of the providers, vendors, might not be quite ready for that. So we will be doing a hybrid in the beginning where so many times a day, those providers will send us a flat file of how many beds they have available, and we will upload that to the registry. Let's see. Yes, so the data will be on a computer, on a pad, on a phone, and as I said, everybody's going to be onboarded by 2024. So I did ask our team, can I have a mock-up so I can show everybody? And they did not, because they're not completely done, they didn't want to disappoint. So they said, can you just list the elements? So you see the elements listed here. They were all approved by Access. Solari absolutely concurred that these were all of the things that we would need. So your facility type, the name, the location, the contact information. So what's the phone number to call to admit a patient? What's the population they serve? Adults, children, maybe court-ordered treatment. What are their available services? Do they have any specialties? And then obviously their total beds, and then the beds available will be calculated by the registry. So the user will be able to look at the registry on whatever medium they have. Like I said, if they're out in the field, they might have a tablet, and they'll be able to sort by closest, sort by facility type, sort by child services instead of adult services. And I love that our designer is going to color code it so that somebody who suffers from color blindness will be able to see the red and be able to see the green. So I'm really happy to hear that she wanted to do that. I thought that was very innovative. So that's pretty much sums up the work we've done and how we're going to proceed and what the timeline is. But as I said, more importantly, we really want to hear from these folks. We have, let's see, yeah, we have about a half an hour, I think, to hear from y'all, and then we'll take questions. So write down your questions that you have throughout, and then come up and ask. So CJ, I want to start with you. You know, given the REBA each had their own system for this, why did Access choose to develop it at a state level?
Well, the regional systems were working, but they were not the same. We weren't consistent. Access didn't have any visibility, and the providers, crossing the regional boundaries, had to use a separate system. It was a lot of administrative burden as well, and we really want to get in line with that best practice and really look at our whole state. What's cool with the dashboard for our providers, as Dana and Andrew will talk about, is real-time information. And that's critical when you're talking about seconds really mattering in a life and death situation, right? But as for Access and the REBAs on that back end, that data lake, that data warehouse that's going to be really watching where a person moves through the crisis continuum is what's super exciting, to take that from regional and pass through reporting through the REBAs and coming through and trying to aggregate and all of that, which takes a lot of work. And is so time delayed that really reacting to a crisis type situation is almost impossible when you're talking about allocating resources and identifying trends where we really could make a difference and save a person's life.
Absolutely. So Dana, then how would a statewide system help CBI's mobile teams as well as your treatment facilities?
So in order to answer that question, first I would like to paint a picture for you all of community bridges and the services that we provide. So we provide services that range from 23-hour crisis observation to inpatient, including involuntary petition, to residential. We have crisis mobile teams throughout the state. We also provide integrated care services, including adolescent outpatient, and we also have other navigator services that we provide. We have 8 total facilities today that provide 23-hour crisis ops, inpatient, or SRU services. And among those, we have a total of 171 23-hour crisis observation beds. We have 110 inpatient beds, and we have 16 SRU beds across the state. Of those, out of all of those, we have around 60,000 admissions, or we've had that within the past year. 90% of those admissions occurred here in Maricopa County. So in answer to that question, first, having a statewide crisis bed registry available would primarily help us with, simplifying the process of identifying an available bed. We have crisis mobile teams that, are outreaching patients that are in crisis. And it is really important, and time is of an essence, to ensure that an available bed is identified at any given facility, really. That doesn't have to be just with community bridges, that can be across the board. Really, we just need to stabilize that patient and get them into care. So that would be primarily, I think the primary benefit of having a statewide crisis bed registry. Secondly, that's going to prevent patients from being routed to locations that are at capacity when alternate locations are available that do have availability. An example of that would be, let's say we have a patient that's routed over to our West Valley location. They're sitting in the lobby and waiting hours to be admitted. When on the east side, we have a comparable location that has availability. The intake process for that patient would be much shorter. Now, I have been advised by our operational teams to make sure that I mention that none of this would bypass the need to establish medical necessity prior to an inpatient admission. However, what it would do is it would give other providers a line of sight into what is available. We have 2 involuntary locations that are available here in Maricopa County. One is on the west side, the other is on the east side. Just giving that line of sight into what is available. And I think, the third way I think this would be beneficial is in eliminating the need for our staff members on site to complete these manual spreadsheets that will disclose our bed availability and send those over to the REBA. That will now be gone, and those same staff members will now be able to focus on providing patient care, which is what is most important.
So Andrew, enlighten everybody on all of the services that Solari has, and we've heard, your company name quite a bit over the last couple days. And then, as you're becoming the crisis hub, help us to understand how important the crisis bed registry will be to your organization's operations, and more importantly, to those we serve.
Yeah, I'm going to piggyback on some of the statistics that you showed earlier and that Dana brought up. Our system here in Arizona is bar none the largest and most sophisticated in the United States. We were looking at that SAMHSA definition of what air traffic control should be. Arizona's ideas for what that is are the most advanced in the country. So they've given us a blueprint, but in terms of who is effectuating that, who's putting it into place, that's really happening here in Arizona. So just to sort of reiterate some of those stats that came out, we're receiving 38,000 crisis calls in a given month. We're sending out 4,000 mobile teams and 1,000 non-crisis transports. The main thing to get from that is that this system is huge. We saw that list of providers that Nancy showed us. All of them are using different electronic health records. Each of them has different data sets. And to make a system that Access is built where there is going to be a single hub and an idea that every Arizonan should be able to access the same level of crisis services no matter where they live, we need to build systems that talk to each other. They need to integrate better than they have ever before, and I think we are in a place technologically where that is possible. So when we talk about what does the crisis system do, we've got the 3 parts that Nancy talked about. We've got our phone calls, we've got our mobile teams, and we've got our facilities. Right now, our phone system is 100% integrated with our mobile teams. So when somebody calls into the crisis line, one of our staff members will take a note, they'll type it in. That note automatically goes to the mobile team that's being dispatched. They're reading the exact note that was put into the system at Solari at whatever different provider is going to go out and work with that individual in the community. In addition to that, we have GPS in the mobile units, so we're actually giving turn-by-turn directions to where they need to go to engage with that person, and we're able to see where they are every 2 minutes to make sure that they're safe. So when we're talking about integration, that is the highest level. Their notes they're looking at our notes after they go out and they interact with that individual. We receive the disposition. So there's complete unity in the system from step 1 to step 2. What we're doing here is we're making step 3 part of that process where we're getting to that level of integration that Dana talked about. So Solari will be able to sit back as the hub and watch a person move from the phone call to the mobile team to the facility. We know where they are in each part of that process. And ultimately, we want to be in a place that that data is shared so that all those providers can speak with each other about what's happening with that individual. The other piece that we get to that is that Access is going to get data at a level that they don't currently have. They're going to be able to see each of those facilities in real time, push that data up. They're going to see if a person went to one facility and then went to another one 3 months later. And right now, we don't have that type of data matching. So for us, this is really a first step in seeing that bed availability, getting that connection where we have eyes on what resources are available to our community members, and making sure that they're getting those resources as quickly as possible.
So my next question was, and I think, Andrew, that you answered this already, but for CJ and for Dana, so how does this work look today, and how will the registry change this? So you want to go first, CJ?
Well, I don't see the work a lot. We probably should let Dana go first, but I'll do my best to remember what it looked like back when I worked with people in the field and sat in crisis facilities. But really, if you walk into a crisis stabilization unit facility, it doesn't matter who the provider is, there is inevitably going to be a group of clinicians and social workers sitting in a pod, feverishly typing and making phone calls and trying to figure out the next step for a patient that's on the ops unit. That seems to take up a great deal of their time. And as Dana had spoken to, in addition to that, then when they do find that place that is open and willing to take them, they've got to fill out a spreadsheet, and then somebody's got to take that spreadsheet and scrub it, and then somebody's got to send that over to the REBA before we can get back to real patient care. That's what it looks like today when we talk about what the HL7 data migration will eliminate. All of that. I can now open up my iPad, my phone, or my computer if I'm the social worker at the OBS unit and say, I've got a child, he needs this kind of specialty, where can I call first? And just really streamline that. On the back end, providing that additional resources on the floor to get back to patient care. But Dana, welcome to add to that.
You explained that beautifully, CJ. You really did. You know, and there are some barriers that are in place because in reality, our crisis mobile teams will outreach, right? They'll go to outreach the patient. You know, there's potential sources of you know, that they can refer them to, but they call these facilities and they find out they have no capacity, there is no room, or, you know, for whatever reason, they're not able to take the patient to that specific facility. So, you know, that poses a barrier. So they go back to the drawing board. I'm sure they're reaching back out to Solari. It really is this cycle. And in the interim, you have this patient who is in crisis and is you know, really just needing care. And so that can be very defeating to see that happen. So anything that we can do to remove, you know, the manual workflow, you know, anything that is repetitive and redundant that we can automate is imperative, you know, that we move forward with. We have the manual spreadsheet process. We have patients that are coming into the lobby, and when the lobby is full, it gets kind of crazy. You know, there's a lot happening in those lobbies. And so we want to make sure that we are providing, you know, a streamlined, safe admission experience for these patients, because we want them to get the help they need, and we want to help the community. And so we really do need to work on our strategic efforts with this.
So could you kind of walk us through how that looks? A call is received, the team is dispatched, they get to the corner of 7th Avenue and McDowell, and the person in crisis is there. Then what happens? I mean, they try to stabilize them, but if it's evident that they need a higher level of care, what happens next? Do they go to one of your facilities? Do they try to find out from there where they can be admitted? So kind of walk us through that whole process, how it looks now, and how long it takes. And we'll contrast that with what will it look like after the registry is fully operational.
So at times what we'll see, and it depends on the area because we have CMT teams throughout the state, but that actual team that goes to outreach the patient, if there is an appropriate, you know, service available through our organization that's easily accessible, then they'll follow an internal referral process with that to accomplish that. They'll take it from there. If there's an external entity that has to be contacted in order to, you know, to provide a referral for that patient, They'll either work with those community organizations or they'll reach back out to Solari for help.
So CJ, what's your future vision beyond this initial project?
Nancy, you know that would take me all day to answer, and
Go-
these poor
go-
people have been here for 2 days.
We've got time.
But for the crisis bed registry, to me, we're starting out in the pilot, is really our main crisis providers that operate under that no wrong door policy, but overall, what we really want to look is at the end of the day, when we get to 2024 and those inpatient units are involved, and it's that two-way communication, not just the front door, not just the crisis observation, but if a person gets there and they need a higher level of care, the time it takes for those observation units to coordinate with the inpatient units is much more extensive even than the mobile teams are having in the field. So, from a member's perspective, a person in crisis standing on the corner of 7th Avenue and McDowell, we do want that to be the first thing, that those mobile teams have that quick access. Imagine yourself standing next to your family member, waiting for someone to call 16 different facilities, getting told they can't take your person. And even if that only takes 15 minutes, that's one of the worst 15 minutes of your life, and it feels like a year. I've experienced that with my own brother. My vision is that this will stop that immediately. And in the same time, we will be able to eliminate some administrative burden and let these crisis experts and these behavioral health professionals get back to the work that they're doing and they need to be doing, involving patient care.
Yeah, because the way I understand it now, the REBAs basically have spreadsheets and it's all manual. And so, going to an effortless system, you can imagine how much time and energy that's gonna save. This first round is getting the providers on this list active in the registry. Hopefully, all of them will be sending the HL7 data automatically by 2024. And then, again, talk about future facing when you could start drawing data, which would be another phase of the project, drawing data. What kind of data? I think, Andrew talked about a little bit before, but, what are you looking for trends? You're looking for members? What all will you be looking for, again, as that perfect future for this registry as far as data goes?
There's going to be a ton that I think Access will be able to leverage right now. The example I gave that Dana for what it looks like in real time, that my days as a provider were 10 years ago. This hasn't changed. So my excitement that we're even starting is really there. But I imagine that we will really be able to pull some meaningful data on what the patient journey looks like, and that will help us inform decisions for where to put financial resources when we have grant opportunities, decisions on where we need to maybe strengthen contract language or policy languages, or maybe even look at policy restrictions and requirements now that are causing barriers to that next level, least restrictive, least invasive level of care. I think that without the data, without really being able to tell a valuable data story, we've been kind of relying on, and luckily here in Arizona, we have a wonderful network of providers who give us their thoughts and their feedback. Our REBAs work very well together and give us that thoughts and those feedbacks, but we'll really have some data behind it so we can make data-informed decisions when it comes to financial responsibility with the dollars that we're putting into certain projects, resources in rural areas and what that looks like, what the journey looks like if you live in Yuma versus Maricopa County or Mojave. I don't want that journey to look any different based on where you live. If you're an Arizona resident and you need care and it needs to be coming through the crisis system into our behavioral health continuum, that needs to be seamless and get you back to your life as soon as possible. We know that that impacts so many other things in a person's life. And this data is going to give us a first look. We have a whole team over there of people that work at IT that understand data a lot better than me, but I'm really excited to see where it goes. I think the REBAs are really going to be able to leverage this as well. They've all done a great job at cultivating very innovative crisis networks and behavioral health continuums post-crisis. And I think that this will really help them even match up that journey and work together and seamlessly make the continuum the same across our state. So again, where you live should not matter when it comes to accessing care.
And I believe, does everybody know what REBA stands for, Regional Behavioral Health Authority? We have 3, as I said earlier. Mercy Care is a central GSA, and we have one in the north and one in the south. And they used to do all the behavioral health services for Access, and then once Access became integrated, now it's services for folks that are deemed to be seriously mentally ill and crisis, right?
Yeah, those living with serious mental illness, crisis, and all of our other non-titled funding projects.
Right.
So we have grant dollars and state appropriations and things that fund programs that Medicaid just isn't able to pay for. And so our REBAs are the administrators of those dollars throughout the state.
Yeah, and I was actually at Mercy Maricopa Integrated Care for 4 years, and I tell you, the folks at these plans really care about their members, and especially folks that are in crisis. I can remember many hallway conversations where there was a member in crisis, and they care, and the sooner that they can get help to folks, the better, for the folks and for everybody in the system. So Andrew, you had mentioned earlier, and I believe this to be true, that we're kind of leading the way here in Arizona for this. So we're kind of the first. So maybe in a couple years, we'll be on the stage at the national conference for behavioral health and talking about how we stood this up in Arizona and how it's working so that we can help other states. Solari now is in Oklahoma.
That's right. Yeah.
So I'm sure they'll benefit from Solari's work here. Andrew, what are your thoughts on that?
Yeah, really, we're able to go into some other states, and we're bringing the lessons that we learned here in Arizona. It's funny when we're talking about sort of what our next steps are for this system and having this crisis data repository. It seems really simple. It seems like an easy concept, but really we're building off the foundation of what we have put together here through Access and this vision of having a single crisis system for the whole state. So when we talk about our inpatient facilities, our subacute facilities, that is the blueprint that the rest of the country comes to Arizona to copy. That is what we brought out to Oklahoma and said this is the way that they should be functioning. And I think that really says a lot about where we're starting off with. We're getting this bed board, and it's going to improve our visibility into the system. But today, if I sent somebody to any one of the subacute facilities that we have, they would take them. Doesn't matter how busy they are, they're going to take them. They're going to find a solution to make sure that that person gets the care. What we're talking about is going steps further. We're getting more complex. We're already doing things that other states are dreaming about. And this idea of putting all that data into a single repository, helping the individuals, and then putting it together at a system level, that's what's beyond everybody else.
Yeah, so this is one reason, the work is fantastic. Knowing that, we're affecting people we serve at Contexture is obviously at the forefront of our mind, but also being, one of the first in the country and being innovative is just so important to us in our work, and so we're excited about that. Dana, any more thoughts about, what this is going to do for CBI? Have you had a conversation yet about what the workflow will look using the dashboard? Are you looking forward to that?
So we have been more, or I guess I would say primarily focused on what that's going to look like, to feed the values over to the crisis bed registry. When the final design is released, I think we will have more information. But I do have a bit of advice for everybody in this room. If you are operating an in-bed facility and you are looking to participate in an initiative such as this, I know that can be a daunting task. At Community Bridges, I will tell you I work in the IT department. And on my team, we do not have an interface expert. Okay, so when we were faced with this, when we were presented this challenge and this opportunity, we really had to internally take a step back and conduct a SWOT analysis. How would we be able to participate in an initiative such as this? What were our strengths? We're charting on these patients. We're admitting these patients using our EHR. We have a bed board. we are capturing all of this information, all the information that is needed, we are already capturing that information. What are our weaknesses? We're operating out of an outpatient EHR, and that is something that was mentioned earlier. How do we get this outpatient EHR to send the values that we need for this in-bed initiative? How do we do that? Opportunities. The opportunity that we had was to take a step back and really, really have a seat at the table in the design of this. We had an opportunity to customize. That was really what we had an opportunity to do. And what would be the threats? It would be that maybe our vendor wouldn't work with us. But I will tell you, if you take the steps needed and you reach out, chances are likelier than not that you'll be able to identify a solution in a way and a path for you to participate in this.
So we have a project manager that's going to work with each provider. And then I don't think I mentioned earlier that Solari is going to partner with us on the provider side if anybody needs help with workflows, designing workflows. Because again, we want this to be effortless and efficient. And so that is another way that Solari is going to work with this on this. All right, so we have a couple of minutes left. Do each of you just kind of want to sum up your thoughts, and then we'll go to some audience questions? CJ?
Sure. I'm really glad that Dana brought up, the initial level of effort on the providers and really looking to that long term. That is something that we thought about ongoing as we developed the task order and have talked through. Is like, hey, what is this going to do to the right now that we already know is a burden on these administrative folks and the clinicians at these facilities. But I do appreciate that all of our providers that are in the pilot and those that are very excited to join have really dedicated time and effort. But again, we really want to know if there is something that we can do to help, and I know Solari is willing to help in Contexture as well. I'm super excited that we're doing this project with Contexture and that we have the opportunity to leverage the HIE and connect some of these, like we talked about or we heard on the previous panel on just how important it is that this information flows in a place where we can use it to be meaningful data and data-driven decisions that affect our entire state. And so I am just more than excited for this, so I'm probably just going to keep talking in circles. But happy to keep talking if we need to fill time.
Well, I can follow up on what Dana was talking about as well. To be in a conference like this hosted by an HIE with other HIE providers here, this is the future in the way that people should be thinking about our systems. It's got to be about building systems like Dana was referencing, where the concept is that we are going to have to take data out of it and put it somewhere else. Gone are the days where we ask all the providers to use the exact same system so that we can, make dashboards and try and send out mobile teams, inpatient facilities, and call centers all in a single EHR. There's some folks out in the country that are trying to operate that way, but that's just not realistic for how sophisticated these systems are getting. We need specialized programs, and when we're designing and building them, we have to be thinking about how's that data come out, where do we put it, and how do we look at it? And if we have that as our perspective, that's going to be the vision for these type of programs to get off the ground, and that's what's exciting to me.
Dana, any closing thoughts before we take questions?
I'm just really excited to see this, this dashboard.
Yeah, and we did, I didn't mention that we do have the differential adjusted payment for this year, that we were offering a percentage to participate. If you participated this year, meet the milestone by signing your scope of work on time. And we'll see if we have funding to do that next year. But that helps offset any vendor cost that they might have, because we don't want to put a burden on the facilities. So that was a way for us to help out providers financially. Robin, what is your question? Can you turn that microphone on?
Thanks.
Thank
so
you.
I think you both just kind of answered a piece of my question. Providers like CBI have disparate electronic health record systems, and so their data to feed into the platform obviously requires some interface that costs money. So congratulations on getting some money on the differential payment. That's great. And hopefully, that'll sustain whatever costs it's going to take to maintain this forever. I want to go back to a slide, though, Nancy, that you started with, which really explained Contexture's role, and that's what I'm wondering if you could just sort of reframe that. So Dana's data is going to interface still with Solari, so that her progress note, Solari picks up somehow, correct?
No, so each of the facilities will send their data directly to the Contexture repository.
So there's going to be some type of login interface that Dana's going to have to do to get to this platform to be able to see what is available to then coordinate the care with the platform. And you're going to get that data feed from the crisis stabilization units on a real-time basis, that they're going to be updating their EHRs so that you know real-time what beds are available and what beds are not.
Yes.
Okay. Then maybe I don't have any more questions, but thank you for explaining that. I just was remembering back to your original slide. You're hosting that platform at the Contexture level.
Yeah, so the repository, for CBI in Phoenix, CBI in Phoenix will say they have 45 beds available on any given time, and then as an HL7 is sent saying that someone was admitted, well, then it becomes 44, right? Oh, somebody's transferred, well, now it's 45, simplistically. And then if they have, say they have a problem in a room where a bed's not available, then they can report that to us. There'll be a workflow for that. And then, as I said early on, for those providers, we want to get this stood up as soon as possible. So for those providers whose vendors need more time to get that bridge built to send the HL7 data automatically, they'll be sending 2-3 times a day a flat file, and then our folks will integrate that into the dashboard, and then it'll go back out. So again, real time is what we want, what the goal is, but we have to understand that the facilities are at different levels to have different EHRs. Their vendors, some move at the speed of smell, and some a little faster, and so yeah, so it might not be 100% HL7 right away, but that's our goal. So anybody else?
I did want to add to that a little bit. So, for Robin's question, I know we referred to 2 different interoperability efforts during our session today. So the first one is we do have an API with Solari, so when they activate our crisis mobile teams, we do receive those messages directly within our EHR. Our crisis mobile teams also receive a dispatch via the app that they use. So that would be one part of this. Now, in terms of the crisis bed registry, every time a patient is admitted or discharged from a program with a bed, there will be an HL7 transmission that will be sent over to Contexture via our HIE interface. Now that will be automatic. They will already have the total number of beds available at each facility as well as the types, and they will use the admissions and discharges to control the bed numbers and the counts that will be displayed on the bed registry dashboard. So I hope that helps, Robin.
Well, we certainly appreciate all the work that you're doing with us on this, and appreciate our team for the great work they're doing on the bed registry. And thanks for coming out today.